Dr. Jacobson is a primary care pediatrician in the Division of Community Pediatrics and Adolescent Medicine at Mayo Clinic and holds joint appointments in the Division of Pediatric Infectious Disease and Epidemiology. Dr. Jacobson serves as the medical directors for the adult and child immunization programs at Mayo Clinic in Rochester and Casson, as well as Southeast Minnesota Mayo Clinic Health System, and serves as a co-chair of the AskMayoExpert Knowledge Content Board for Immunizations and Vaccinations. He also conducts research to improve vaccine uptake and has published over 281 peer-reviewed publications. He is passionate about evidence-based medicine, population health science, and preventative care, including and especially vaccines. And he and his spouse, Renee, have raised 4 well-vaccinated children. Thank you, Dr. Jacobson. I'll turn it over to you.
All right, thank you. And I want to thank everybody for joining us in this webinar. I've entitled it, No Thanks, Doc, Tools to Improve Difficult Vaccine Conversations in the Medical Encounter. I got to make an acknowledgement. This presentation was originally developed by the North Dakota State University's Center for Immunization Research and Education, or CEIR, with funding from the Minnesota Department of Health. I have 3 objectives that I'd like us to accomplish in this presentation. That you'd be able to discuss the history of vaccine hesitancy and the current state of ambivalence, to be able to analyze strategies for addressing ambivalence and vaccine hesitancy with patients at the medical encounter. And then finally, that 3, you'd be able to improve your confidence and comfort in addressing common vaccine concerns around the HPV vaccine. Let's begin. First of all, let's take a moment to celebrate what huge impact routine childhood vaccination has had on annual morbidity from a lot of vaccine preventable diseases. Now, we have here a listing of vaccine preventable diseases on the far left. Then in the next column, 20th century annual morbidity before we start vaccinating against that disease. And the year that that was calculated really depends on when the vaccine was introduced and represents a snapshot of what this country looked like before we start vaccinating. And then with our most recent data in the next column, have the 2023 reported cases of these diseases. And then over on the far right, a calculation of the percentage increase. And the top of the line is smallpox, which we have eradicated from the planet. But before we were vaccinating against smallpox routinely, we had 29,000 cases a year in the US. 2023, 0, 100% decrease. Diphtheria, one of the worst diseases we've ever faced, with a mortality of 50% if not treated and 10% if treated. We used to have 20,000 cases a year, down to 2 cases in 2023, more than a 99% reduction. Measles, basically every child in the country got measles. And so it was basically the birth cohort every year. The reported cases were about 500,000 a year. We got that down to 47 in 2023. Now, I know right now we're in the midst of an outbreak of measles in part through vaccine refusal and hesitancy, but still overall, we have reduced the amount of measles by more than 99% with vaccines. Mumps, 162,000 down to 429. Whooping cough or pertussis, 200,000 down to 5,600. Polio, 16,000 down to 0 this year, 100%. Rubella, German measles, 47,800 down to 3 cases a year. And we more or less wiped out congenital rubella syndrome, where non-immune pregnant individuals acquire rubella infection during pregnancy and then have problems with the pregnancy, and the child is born with congenital anomalies and brain damage. 152 down to 0, 100% reduction. Tetanus or lockjaw used to have about 580 cases a year, down to 15, 97% in reduction. Haemophilus influenza, a major cause of meningitis and sepsis in babies, 20,000 a year down to 27 cases a year, more than 99% reduction. This is just amazing to marvel at. But we've got a problem. The World Health Organization has identified among the top 10 threats to global health, and they did this in 2019 before the pandemic, is vaccine hesitancy. Vaccine hesitancy isn't new. Here you see a cartoon that was circa the time of Jenner's cowpox vaccine. And if you look in the picture, all these vaccinated people by Jenner are developing little cows on their skin. This was, and the title reads, "The Cowpox, or the Wonderful Effects of the New Inoculation." So we had even vaccine myths and misinformation back at the time of Edward Jenner and the development of the first vaccine. And here, about 100 years later, we see a pamphlet, 150 Reasons for Disobeying the Vaccination Law, by people who are prosecuted under it. So the hesitancy we're facing now is not new. It's been a persisting problem. It does seem like it's worse right now. Hey, let's take a look at the history of vaccine hesitancy. Now, Edward Jenner was promulgating the smallpox vaccine in the 1790s. Back in our country, we were having outbreaks that led to Massachusetts actually requiring people to get the smallpox vaccine, and a Reverend Jacobson actually sued, refusing the smallpox vaccine. This led to an important Supreme Court case called Jacobson versus Massachusetts, where Jacobson lost, and the Supreme Court upheld the right for a community to require vaccination when medically necessary. 1982, we get a TV show called DPT, Vaccine Roulette, that scares parents all over the country with regards to pertussis vaccine, and caused a lot of hesitation and delay in pertussis vaccination. 1998, Andrew Wakefield actually makes up data and fraudulently claims the measles, mumps, rubella vaccine causes autism. The fraud was discovered. The man lost his medical license, and in fact avoids going back to the United Kingdom because he would be arrested if he returned. But the vaccine autism myth persists. Despite many studies now showing vaccines do not cause autism. 2000 to 2025, we still, despite all that, saw an increase in measles outbreaks, and you know what we're dealing with this year. 2019, the COVID pandemic actually caused disruption worldwide in medical care, but also caused for a lot of people a growing distrust of public health and of government. So now we see in this graph entitled "Americans Are Less Likely to Say It's Important for Parents to Have Their Children Vaccinated," the percent who say it's extremely important to have their children vaccinated in 2001 was close to 100%. This was extremely very important, at least very important. I think these might be flipped, but anyway, you see that they drift down. Extremely important drifted down to 69%. Extremely very important, or maybe this is extremely mixed with very important. This is extremely, but you see this drift down of both those groups from 2001 now to 2024. very frustrating that fewer and fewer parents think vaccination is important. And there's a growing minority of Americans who say vaccines are more dangerous than the diseases they're designed to prevent. Look at that. Back in 2001, 24 years ago, it looked like 6 or 7% of parents would say the vaccines are more dangerous than the diseases they present. But it crossed the 10% line in 2017, and now in 2024, it's at 20%. It's a concerning trend, and during the 2023-2024 school year, coverage declined to less than 93% for all reported vaccines for kindergartners due for their routine childhood vaccines, and exemption rates increased to 3.3% from 3% the year before. The problem is getting worse. Vaccination coverage year to year in Minnesota in 13-year-olds and 11-year-olds has continued to sputter along, never reaching our healthy people 2030 goal of 80% across these vaccines. But for meningococcal vaccine and Tdap, you see it below 80% year after year, maybe a little worse than it was here in 2018. HPV series initiation and HPV series completion even worse, with the initiation being 50s getting up to 55, but not getting over 60, much less 80% or higher, and completion among the 11 to 12-year-olds, not even 30%. The trust in personal doctors and government health agencies has declined since 2023. This is the percent who say they have a great deal or fair amount of trust in the following to make the right recommendations when it comes to health. First of all, their doctor. 2025, it was measured at 85%. We were doing much better in June of 2023 when it was 93%. But look at these groups. The CDC fell from 66% to 61%. State and local public health officials fell from 64 to 54. The FDA fell from 65% to 53%. The fact of the matter is hope is not lost. Research still indicates, as that graph did, healthcare providers are still the #1 trusted source for parents for vaccine information. And healthcare providers use a presumptive language to signal their strong personal recommendation, and their use of motivational interviewing techniques to address vaccine hesitancy works. And not just in observational studies, but now randomized controlled trials show that the combination of these two can really improve vaccination rates. And I want you to be able to use both of those skills successfully with HPV and with other vaccines. Be not afraid. Familiarize yourself with the vaccine safety monitoring systems and be comfortable in responding to common vaccine concerns. Don't underestimate your expertise or your standing with the patient's parents. After all, they're in your office seeking your advice. They came to you. Don't be afraid to use your advice to make strong vaccine recommendations and deal with their concerns. Let's talk about communication strategies to address vaccine hesitancy. First of all, you gotta know this study, and it's been replicated now twice, actually 3 times now, and continues to show repeatedly what Brendan Nyan and his colleagues found with this study. Now, in this study, the researchers asked this question: which message works best to increase vaccination rates for MMR? They sent educational material to people of parents' age for the measles, mumps, rubella vaccine, and they used either corrective information about the lack of evidence for the measles, mumps, rubella vaccine causing autism, or sent text information describing the dangers of the diseases prevented by measles, mumps, rubella vaccine, or sent them images of children with diseases that the MMR vaccine presents. In a fourth group, they were randomized to get a narrative from a parent, a story of their near-death experience with their infant with measles, true story. The fifth group actually got nutritional information, had nothing to do with the MMR vaccine or autism. And then Brendan Nyan, after 2 waves of this educational material, asked the people what their attitude was about the MMR vaccine. Oh my gosh, the results are frightening. None of these worked to improve their attitude towards the vaccine. None of them did. In fact, the corrective information about the vaccine and autism decreased the intent to vaccinate in the most hesitant parents. The images of children with diseases of MMR vaccine prevents, without ever mentioning autism, actually increased the individual's belief that there was a vaccine autism link. And the parent's story of their near-death experience with their infant with measles actually increased in those people a belief of the serious vaccine side effects. All this is to say, educational efforts alone don't work. You can't educate a parent who's hesitant hesitant for vaccination alone. That isn't going to solve their problem. It won't solve their hesitancy or their ambivalence. So what are you to do? You need to assume a presumption that the parent's here for your advice. Assume that they're going to vaccinate. Go into the office with a positive attitude. Make a strong recommendation for the vaccines the child's due. Strong provider recommendations are correlated with increased vaccine acceptance versus using what you might call participatory communication. Presumptive language might sound like this. I see Michael is 11. That means he's due for vaccines against meningitis, HPV cancers, and whooping cough. That's using presumptive language. You're assuming that the parent is here for your advice. You're giving them the advice the child's due. Very different from language such as, are you doing shots today? Are we doing shots today? Which makes it sound like it's an option, that they're going to get their visit with you. They're going to get their advice with you. And do they want this as though you're offering a side of French fries? Now, observational studies and randomized controlled trials have shown dramatic improvement in vaccine uptake when parents receive a clear recommendation for the children to get the HPV vaccine. They have about 10 times the higher odds of getting their child vaccinated that day. It really works. The presumptive method works. It improves vaccine acceptance. It's similar to the approach you use on basically everything else you do in the office. You say your child needs an x-ray. I need to take a look in the ears. We need to test this for strep. Once you make the diagnosis of strep throat, you use presumptive language. I'll prescribe you an antibiotic called amoxicillin to treat it. You don't use participatory language. You don't say things like, she has strep. Do you want to have amoxicillin to treat it? Think about what you're sending implicitly or subliminally. When you make a strong recommendation, your child's due for the vaccine, your child needs amoxicillin, I'll write a prescription for amoxicillin. That's basically making clear you really recommend the child get that. There's not really a good other option. The participatory language really makes it sound like it's an option. Indeed, like the parent might want to seriously consider not doing it. When you say, did you want to get the flu vaccine today? You send a message that you could care less about the vaccine, and it's completely up to the parent. Using the presumptive strategy actually will save you time, because you'll have a lot of parents whose hesitancy resolves when they hear your strong recommendation. But what if the presumptive language doesn't work? What are you to do next? This is where you use the tools of motivational interviewing. The spirit of motivational interviewing, or MI, is a partnership with the parent, acceptance that they're part of the equation, that you're going to evoke a sense of trust and an awareness of where they are in their journey of making a decision, and you're going to be expressing compassion in doing so. We're all on journeys getting somewhere. You're going to help the parent on their journey towards a comfort level with your recommendation of the vaccine, and you're going to use patient-centered guiding communication style for enhancing the parent, the person's own motivation for health behavior change by exploring and resolving their ambivalence. Remember, the parent came there for your advice. They actually have the child's best interests in mind, even as they hesitate about the vaccine. They want to do well for the child. Studies have illustrated the effectiveness of using motivational interviewing, or MI, with patients and parents considering behavior, lifestyle, addiction changes when ambivalence is present. Well, if we can use it for those behaviors, we should be, and now we have evidence supporting our ability to successfully use motivational interviewing with vaccination. And we have shown that you can address hesitancy when present with motivational interviewing and get parents to adopt routine vaccination. So think of the ambivalence that you're addressing with motivational interviewing as another word for hesitancy. In the back of their heads, they know there's some pluses about the vaccines, but they have some minuses, and they don't know where they are right now in sorting that out. Rather than argue against a person's ambivalence, honor it, recognize it, say it out loud. Understand that ambivalence is a normal part of the change process. Recognize that ambivalence is a state of mind coexisting, but with conflicting feelings. You're going to use communication techniques developed in motivational interviewing to help your patient with vaccine hesitancy, using open-ended questions such as, you aren't sure about the HPV vaccine today. What worries you? Reflecting back to demonstrate that you've heard the patient. You're really worried about the ingredients in the vaccines. You honor the ambivalence. So you don't want her to get cervical cancer, but you're worried about the long-term effects of this vaccine. Many parents feel that way, making the parent feel a little more comfortable in their ambivalence. Asking permission to share. Can I share some information that I think might ease your mind? Make a personal recommendation. My own children have gotten the vaccine, and I recommend it to all my patients. But support the parent's autonomy. He is, after all, your child, and this has to be your decision. I want you to feel good about your decision. Motivational interviewing consistent strategies to consider would be scaling questions where you ask them on a scale of 0 to 10 where they are in accepting the vaccine, and using what we might call elicit, provide, elicit to move them in their ambivalence towards an informed decision. You ask questions, provide information, ask further questions. Okay, let's go through this with two really good examples. Case study 1. The doctor says, everything on your son's exam was fine. Next, we'll have the nurse return to conduct the vision screen and the HPV vaccination due. Do you have any questions? Hey, this is presumptive language in its finest. The doctor here is doing exactly what randomized controlled trials have shown. You're assuming the parent wants the vision screen and the HPV vaccines that are due. You aren't saying, what are your thoughts about the vision screen? What do you want to do about that HPV vaccine? You're saying, well, this is their next step in this process of this visit that you scheduled with me. Now, you do offer for the parent to ask questions, as you should, at the end of your recommendations, and that's what the doctor's done here. But in this case, the presumptive language doesn't work. Wow, HPV, isn't he a bit young for that vaccine? He's only 9 years old. Now, in our clinic and in this doctor's clinic, we routinely vaccinate against HPV starting at 9 years of age. The CDC has given permission to do that since 2006, and our clinic at Mayo Clinic has routinely started at 9 years of age. So the doctor answers, that's a great question. And you aren't my first patient to say that. Can you tell me more about why we should consider starting? Can I tell you more about why we should consider starting this vaccine at 9? Look at the tools of motivational interviewing at work. You recognize hesitancy or ambivalence. You acknowledge and affirm, that's a great question. And you make the person feel better about the question by adding, and you aren't my first parent to say that. Now you ask permission. That's important. You're not having an argument. You're not having a debate. This is not a Lincoln Douglas debate where the father takes one side and you take the other. You ask, can I tell you more? Can I let you know what I think? Elicit, and then you're going to provide, but only with permission. The parent says, sure. So starting early may improve on-time series completion. Certainly what we found here at Mayo Clinic across the enterprise and what other studies have found across the United States. Increasing the number of adolescents who begin HPV vaccine at age 9 may lead to improved cancer prevention by maximizing the number of people protected through on-time vaccination. The most recent national immunization surveys of teens showed an uptake of Tdap at 89%, and the first dose of meningococcal ACWY was at 87%. But HPV rates remain significantly behind these vaccines, with initiation at 68% and completion at 51%. And there's no known downside to starting earlier. This is not a vaccine that wanes. You get immunity for life. And it gives you an opportunity to complete the series before the other vaccines are due. So you got 1 or 2 injections at a visit and not 3 or more. Implementing the HPV vaccination at the earliest opportunity produces a really strong immune response. Our 15-year-olds who start the series don't make the antibodies that our younger children do. Our 20-year-olds who wait to 20 to get the vaccine get far less than even the 15-year-olders get. So back to our case study, the doctor answers, we start the HPV vaccination around 9 because this vaccine is really all about cancer prevention, protecting Lenny long before he'll have contact with the virus. Starting Lenny now also means we're more likely to finish the series and provide the protection Lenny needs. Now you've provided, but it's elicit, provide, elicit. Let's elicit some more. The doctor says, what stands out to you about what I shared? I appreciate the information. I guess my biggest concern is my wife and I didn't even start thinking about HPV this early. We haven't really prepped Lenny for it today. The doctor answers, I can appreciate your concerns. On a scale of 0 to 10, how confident are you in vaccinating Lenny against HPV today? Oh, maybe a 5. Now look, if the father had answered 0 or 1, you might at that point feel like you're not making the kind of headway. But a 5, why? That's smack dab in the ambivalence. Perhaps you can continue to pursue it today with motivational interviewing. And this doctor does with, great, you said 5, why not a 2 or a 3? What's swinging you more towards vaccination? Well, the father does say, I guess I do want Lenny protected from things like cancer. But like I said, we haven't really prepped him for it today. The doctor answers, I hear what you're saying, acknowledging the father. would anything get you to a 6 or 7 today? And the father says, I guess more details on why Lenny needs it now rather than 11 or 12. You come back. Mind if I provide you some additional details? Diego nods. We know that giving this vaccine at 9 or 10 also produces stronger protection than later in adolescence. Also, if we start the series before 15 years of age, Lenny only needs 2 doses to be up to date. That means less shots at his next well child visit at age 11. What would you like to do? I highly recommend the HPV vaccination. All my patients recommend we get Lenny started today. The father says, okay, let's do it. Great, I'll have the nurse come in, and I'll have that taken care of for you and get him scheduled for the 2nd dose. In that example, we talked about one of the big tools of motivational interviewing called elicit, provide, elicit, or EPE. You ask questions, answer their questions, ask another question. You're not having a debate. You are helping the adult learner master what they want to know. Sharing information using EPE can look like this. Now let's look at the elicit column on the far left. You elicit what the parent knows or what they need to know. And you ask the question with empathy. And then you learn from the parent or patient what they already know. You might ask questions like, what are your specific concerns? What have you heard? What would you most like to know? These questions really help narrow your focus so you aren't giving a boatload of information about something the parent could care less about or already knows. You respect them as an adult learner. And then you move to provide. Provide information, but only after asking permission. If the parent says, no, I don't want to talk about today, you respect that. Stay neutral, validate feelings, debunk myths without reinforcing them. You might say things like, may I make a suggestion? Or this may not fit for you, but some people find. Or would you be interested in some resources? And then elicit the patient's response. Reflect on the discussion. Emphasize they're in the driver's seat. They are the ones who need to make the decision. What are your thoughts on that? How do you think that would work for you? Eliciting the main concern. Let's talk about the varicella vaccine. I don't want my child to get this vaccine. Now, at this point, you have no idea why that parent doesn't want to get the vaccine. Let's find out. It could translate to my child has already had chickenpox, doesn't even need it, to I don't think chickenpox is that bad, doesn't understand the need, or I'm pregnant and I'm not so sure about my child getting a live vaccine, given that I shouldn't get live vaccines during pregnancy. These call for 3 different answers. And if you don't know what the parent needs to know, you're going to be wasting time or just backing the parent up against the wall. So you need to find out, what if you hear from the parent regarding the COVID vaccine, I don't think this vaccine's safe? Well, you don't know what their specific concern is. You want to elicit more information. Maybe you'll find out, I think this vaccine causes female infertility. Maybe you'll hear that I'm concerned about myocarditis. Maybe you'll hear, I heard this vaccine didn't complete the usual clinical trials. Maybe you'll hear, I'm concerned about what's in this vaccine. Depending on the parent's main concern, you don't know what to answer yet, and you shouldn't be. You need to get more information. Let's go with another case study and see this in action. Great to see you, Julie and Carly. I see that we have Carly hidden for a sports physical today. As part of her visit, Carly's due for a Tdap, HPV, and meningococcal vaccines. Any questions? You know, I'm just not sure about Carly getting the HPV vaccine. Uh-oh. We saw a good presumptive recommendation here with Carly being due. but we're seeing ambivalence or hesitancy. We're going to now pivot from presumptive language to motivational interviewing. Can you tell me more about your concern? You are eliciting information. You are asking enough that you can be of help. The parent says, thanks for asking. I've done some research online and I'm worried about how safe it is. I read it may cause something called primary ovarian insufficiency, or POI, which could impact Carly's ability to have kids. And here you use another tool of motivational interviewing. You aren't the first parent that's come to me with this information. Can I share some information with you? Oh, that's the second tool. You've acknowledged, made the parent feel more comfortable with the concern, and then asked permission to share information. You get that permission, you proceed. HPV vaccines have been around for a long time now, over 15 years. And during this time, over 100 million doses of HPV vaccines have been distributed in the US. We have very promising and reassuring data that these vaccines provide long-lasting protection and that they're very safe. The rumor that this vaccine causes infertility still makes its rounds on social media. As part of ongoing safety monitoring of HPV vaccines, researchers have taken a look at the risk of primary ovarian insufficiency following both Gardasil 9 and Gardasil vaccination. And many studies looking at hundreds of thousands of girls have found absolutely no link between HPV vaccine and infertility or primary ovarian insufficiency. Some of my patients do experience some soreness, swelling, and redness where the shot was given, but this is common and should get better in a day or two. And do you know what is absolutely linked with infertility? HPV cancers. The fact that they can cause issues with having children is unquestioned in the medical world. I vaccinated my own daughter against HPV and highly recommend Carly get vaccinated too. What stands out to you about what I shared? Elicit, provide, elicit. No, that makes sense. And I guess I didn't realize HPV vaccination has been around that long. I really appreciate you taking the time to talk to us about it. Your recommendations are important to us, but we're going to need to take some time to think about it. Okay, one more example of motivational interviewing. Autonomy recognition. You're in charge. You need to be comfortable with your decision. I want you to be comfortable with your decision. May I send some resources home with you to review? I think HPV vaccination is a very important part of keeping Carly healthy. And the parent says, absolutely. There, you've used presumptive language, followed with motivational interviewing. Key takeaways. Start your approach with the presumptive approach. Make a strong recommendation with presumptive language. Move to motivational interviewing techniques when you sense ambivalence. Familiarize yourself with common vaccine concerns so you can debunk myths and answer questions. You're showing empathy and supporting the parent's autonomy. It's going to break down barriers and will build trust between you and your patient. It's worth doing and worth doing well. You can learn these techniques. There is free, incredibly professionally well done training at SEERMI. That's SEERMItraining.org, where you can learn about motivational interviewing using the elicit, provide, elicit model, using change, talk, and scaling questions, and getting first best responses to parents' concerns. This has been developed and taught by Dr. Mary Larson, a member of the Motivational Interviewing Network of Trainers. Scan this QR code rather than type in that address for quick access to get that 4-part video series through which you can earn 1 hour CME free. This is good material. I've taken it myself. I strongly urge you to do that. Here's another educational effort you can access. This was recorded just a few months ago by John Ulvin from from North Dakota State University's Center for Immunization Research and Education. And this is entitled Change the Conversation, Motivational Interviewing and Vaccine Hesitancy. And that also offers free CME. Either scan this QR code or use this little shortened address to access this learning. I've also gone through this material. It's just as good. Here's another one by Tracy Newman. This is a recording on HPV infection, immunizing for cancer prevention. Scan here to learn more about the HPV vaccine and be ready for your parents' questions. What questions do you have? Let's get those questions answered. You need to learn more about motivational interviewing. You have the resources. You need to learn more about HPV. You now have the resources. Thank you very much for your kind attention.
Thank you for an amazing presentation. Along with this recording, we also have a number of the resources, including the slides, available on our website.